Hi, everyone. Welcome to another edition of 10 Minutes with JPIDS. I'm your editor-in-chief, Ravi Jhaveri. It's really a pleasure to be joined by our UCLA colleagues, former fellowship director and still very good friend, Paul Krogstad. Welcome, Paul.
Welcome. Thank you.
And many of you know former Feigen apprentice with JPIDS, Sanchi Malhotra, who's been a previous guest on our podcast. Welcome back.
Thank you.
Thanks for being here today. We're going to talk about a recent paper that you guys published in JPIDS about coccidiomycosis in children. But before we get there, listeners know that I start every episode with the same question. So Sanchi's answered this before, so Paul, you're in the spotlight here. Listeners know that I'm a superhero nerd, and every superhero has their origin story. So, Paul, can you share with us your origin story of how you got interested and involved in PEDS ID?
There is no question about how this came about. When I got to Tulane Medical School, I thought I was going to be a family practice doc and save the world, to continue that superhero theme. And during my third and fourth years, I had exposure to great mentorship from an entire division. The Pediatric ID division at Tulane, led by Bob Dom, also included some other real greats. Neil Halsey, um, someone who was came in the years ahead to be a great leader in HIV, Russ Van Dyke. Um, uh, I had exposure to um, uh, just so many, I had so many exposures as a medical student to them and some of the other faculty. Margaret Smith was the name I was reaching for. Um, People that just continue to inspire me by their balance of humanity and science and compassion that they brought to each and every day. And lo and behold, when I started thinking about, my composition, the kind of physician I wanted to be, it was to try and model what these triple threats did, and hope to some extent I've been successful in that because they made you want to be just like them by seeing the impact of what they could do with diseases like tuberculosis and Haemophilus influenzae and all these things that seem very common at Charity Hospital in New Orleans. And they brought the whole package. And every day, you just sensed, I want you to know this so that you can do your best for every single one of these children. You know, tremendous exposure. So that's where I came from. That's how I got here.
Love it. All right. Well, thank you so much for sharing that. And if it helps you at all, you have been one of the biggest influences on my career. So I give you a lot of credit. So there's a lot of love back and forth there. Okay. Okay. So let's refocus here. So Sanchi, this question is going to be for you. Can you share with us the origin story of this paper? How did we get started? How did you guys get started wanting to write this paper?
Yeah, absolutely. So I joined UCLA in 2023, and it felt like my first year there was just a revolving door of all these really complicated cases of cocci. And, I'd seen some in my fellowship training in LA, but it felt like we would discharge one, another really extreme case would come by, and we were coming across so many questions of how to handle all these cases that have failed fluconazole. What are next line treatment options, even reaching so far as getting to novel antifungals. So we really wanted to share our experience. And I remember talking to Paul in clinic even and being like, man, it feels like we're seeing a lot of cocci. And he said, yeah, we've seen more than we've seen in my whole career. So that was really striking to me, that clearly this was an increase. And a lot of that was referral bias, which we do address in the paper. But there's also a clear increase in the incidence in California. I mean, we mention it increased fivefold between 2000 and 2025. So this is an issue that a lot more practitioners are going to start seeing if they haven't already.
Yeah. Paul, you have anything to add?
Yeah, yeah. In fact, one of the most recent manuscripts on this topic, the changing epidemiology of coccidioidomycosis from last year, used all the available case report data from the 28 states in the U.S. that require reporting of cocci plus District of Columbia, and they realized, they estimated that we had gone from what CDC had been saying for years about 100,000 cases total to 150,000. And their estimate is probably more like 250,000. So that played out with this 500%, five-fold increase that Sanchi mentioned, that in disease, specifically in children, that had occurred over a short number of years in California. So, I mean, to me, this was pretty stunning, and to realize that now, this changed the character of working with kids with Coxie, because this was no longer that one challenging patient that you were going to encounter. And if you had questions, you'd call a couple of people, and then you do your best, because if nobody's got an answer, I'll scrape together the best data I can and do my best. But this is the beginning of this great big, surge that has turned into a flood that really has dominated what's been happening at UCLA. And to add one more detail, just Sanchi, it seemed that what was happening is that our clinic, was becoming very heavily influenced by the number of new Coxie patients you were going to see every week. You get a couple. There was a little phase in there where it seemed like every week you're getting one for sure, or you're getting one in a follow-up, or you're getting a couple new ones that were a lot to work through, lots of questions. People had waited for a long time to talk to an ID specialist, and we were it. And my part of what was in my head about trying to encourage, to work with the four faculty and resident that are the authors of this paper, was to really just try and create that a palpable picture of what this is like, because that paper that I mentioned, Williams is the first author from that was in JAM open source last year. They helped reinforce what some others have been estimating based on modeling of how the influence of climate change, that the case surge that we've been seeing in the Southwest for some time, is likely to spread into other states in the Southwest. It's likely that by the middle of the century, by 2050, it's been projected that half of the states in the U.S. and the 48 contiguous states are going to be places where would be likely to find Coxie in at least some part of the state. So this is something that we felt, that I certainly felt strongly about, that we need to up our game in PEDS ID. And that was, an underlying thread in this paper for me.
Thanks. Actually, before I move to the next question, it just makes me think. So with the surge in cases that have happened over the last couple of years in California, in the paper you mentioned, Paul, or are there other sources where kids seen in other states or adults seen in other states are either taking longer to be diagnosed or not being diagnosed? Or there's a note that we are diagnosing them because we're sensitized to the increase in case and are doing more testing for Coxie?
Oh, well, certainly in California that occurs. It's been more than a decade in my case where, when lecturing, like in board review, to people doing their initial cert or their recertification for general peds, where I've emphasized, if you see a kid and it smells like what you were taught to look for in tuberculosis in California, you should make sure that you're thinking of Coxie as a greater possibility than TB, because there are more cases of Coxie annually in children in the last decade than TB. And so it wouldn't surprise me if at the moment that if we're still trying to persuade some of our colleagues here in California to remember to think about it when you see any number of scenarios, it's likely that that's going to repeat itself when well-trained physicians in other parts of the Southwest, and indeed the rest of the country, first encounter Coccidioidomycosis.
Don't you want to add anything?
I think also, Paul, in that paper you mentioned, they also demonstrated that the numbers of cases in states that aren't considered endemic was actually higher than states that are low incidence. So the number of cases that'll be seen in states outside of our area is actually going to be pretty significant.
Yes, and some patients, yeah, exactly that. They pointed out if you look at high incidence states, which is really California and Arizona, versus low incidence states like the adjacent states to those two, New Mexico is is substantially lower than California and Arizona and Utah, Washington State. They generate, case reporting, there's a pretty good number there. But when you add up all the case reports from all the other states in the lower 48, that's more than what you see outside of California and Arizona. It's the bulk. So people are going to also be seeing a sprinkling of cases probably because of things like the ridiculous cost of living in California. There's been a net export of population
Yeah.
in recent years, and some of those people, yeah, it's easy to imagine cases where these sorts of cases have been reported and for decades, where someone is in Europe or someplace where you just shouldn't see cocci in Southeast Asia, and it's because they spent some time, visiting
Yeah.
Disneyland or
Yeah. I
going to
think
Vegas
that's right.
or
That's
right.
exactly the point. The same way that we're sensitized in the Midwest to just test everybody for histo.
Sure.
If there's a meaningful exposure or travel, then I think we're adding Coxie to that list. So I appreciate that. Um, you guys touched on this a little bit, but can you maybe reflect a little bit more on some of the unique challenges about treating kids with Coxie compared to adults?
Yeah, there are so many. I mean, one is we really have a paucity of data compared to adults. We're really, I mean, that's true of a lot of pediatric infectious diseases, but we're really extrapolating from what we know from adults. But, even our dosing of fluconazole, they have such standard dosing. We are really trying to play around with that. Our experience with advanced mold active triazoles, a little better studied in adults, but we have such hard times getting levels, whereas in adults you don't even have to check levels for things like isobuconazonium. So there's the challenges of the treatment, but there's also a lot of social challenges. There's only a handful of pediatric hospitals that are comfortable managing these cases, and especially the disseminated cases. So our patients are coming from hours away to seek care, and so when you're discharging them, you're really scared. Are they going to be adherent? Are they going to come for their follow-up imaging? And a lot of the time it's people in Central California that aren't always the highest socioeconomic status. So ensuring that follow-up, I mean, it's devastating when you see a patient relapse because they were non-adherent and
Yeah.
have severe disease, and we just don't want that.
Yeah.
There's also the element of getting our supportive colleagues in surgical fields, for example, to kind of understand what we're working with here. Yes, for example, most patients with, what I want to focus on specifically for a moment is just the multiple musculoskeletal foci that appear in some patients with disseminated disease. And when you've been treating for a week or two, and yet you're still seeing local inflammation, the swollen wrist stays angry, there's still a limp, they're not getting better. Yes, I realize it's a fungal infection. Don't expect the kind of response you'd see with that we've all come to expect with a well-treated osteomyelitis caused by bacteria, the usual bacterial pathogens. But sooner or later, you have to say, are we sure this isn't a lesion that needs to be debrided? And initially, I think it still sometimes is to go a challenge to go to our surgical colleagues and say, I think that you ought to investigate this one because it doesn't seem to be getting better. And that was an initial hard sell with some of the colleagues that we're working fluidly with for decades in pediatric bacterial osteo. And they why would I do this? And the limited literature just tends to suggest that the medications that we're using, the medical therapy that we have for cocci does not always seem to reproducibly work. And you maybe this needs more systematic investigation clearly, but it's not a single experiment in which we have come along and said, this tibial lesion, this other bony lesion just does not seem to be getting better. How about some debridement here? They're in some cases reluctantly agree, but they agree, and then it just seems to resolve soon thereafter. Debulking, source control, whatever term you want to use, seems to make a difference in some musculoskeletal lesions. And similarly, conversations with our neurosurgical colleagues are very important. It's good to establish a relationship to understand the nature of cocci. How many pediatric neurosurgeons in the country have had to deal with this condition? It's one thing to control intracranial pressure. It's another to have to work with them to try and do the intrathecal therapy that with the medications available. Sometimes we feel forced to administer. So yeah, we're still in a tricky place. And the final piece of that, I think, the new phase of this is the use of immunotherapy, which is now really being looked at. Still, it's like the surgical therapy that I mentioned, that some cases it is used and then things change. Similarly, we have I think a growing number of reports, largely from Manish Butte in our division, our division chief of allergy immunology, who's been has taken on the task of really trying to investigate what is pathophysiologically off kilter in those who develop disseminated disease, and look at the effect of using immunomodulatory therapy as an adjunct to antifungal therapy. So, conversations, communication, that's what monitoring, that's what dealing with this disease is like. We do plenty of that with other conditions. This is another example where
Yeah.
we have a lot to work through.
Yeah. So Paul, I know in recent years and in this last phase of your career before you officially reached your emeritus status, you spent a lot of time doing research on pathogenesis and how susceptibility of cocci. Can you give us a brief summary? This is only 10 minutes with JPID, so you're not allowed to give a half an hour talk, but can you give us maybe a high level summary?
Yeah, this is we are in an era that now has been going on for just half a dozen years, let's say, where we're really coming to a deep understanding of the host pathogen interface in coccidioidomycosis. What the disease largely seems to be about is an interface is that interface between recognition of a pathogen by macrophages and neutrophils that produce inflammatory signals in T cells that produce gamma interferon under the macrophage as induced macrophage cytokine stimulus, and the gamma helps stimulate the macrophages. When something goes wrong in that interplay, now that's been associated with the disseminated disease. For a long time, we only had examples of people, for example, with IL-12 receptor defects, with gamma interferon receptor defects, and classic inborn errors of immunity to blame. We only had just these high order things. Now we're coming to understand, yeah, there are genetic polymorphisms in an otherwise apparently healthy immune system that allow cocci to get an upper hand. And the single example that I can come up with, this a simple one, is dectin-1, a C-type lectin that recognizes beta-glucan on the surface of fungi. And it turns out that that probably is overrepresented in certain people, in certain subpopulations. And that plays a role in controlling in initial recognition and initial control of cocci. In 2019, we reported a case of somebody with such a polymorphism with 12 musculoskeletal foci, an adult, in a collaboration with some adult ID colleagues. And it's panning out more and more. So watch this space is the phrase. And if readers want to know kind of where this stands, look at a recent paper by Stevens from UCLA where they talk about in clinical infectious diseases, where they talk about their experience with using dupilumab and gamma interferon in children and adults with this disease, and just keep watching for where we're going in the terms of the development of vaccines based on a better understanding of that. But 20 years ago, there was almost no funding in cocci pathophysiology. Several R1s, I think, existed. And now you have three U19 projects going on. There's been some state support in California. So we're really coming to grips with understanding why some people disseminate, how you end up being in that 1% when you're not somebody with an easily recognized innate immune deficiency or adaptive immune deficiency disorder.
Yeah, cool. Exciting times. All right, last question. And again, you guys referred to this a little bit, but with this increasing burden over the last 20 years, and obviously initially bad droughts in California that is sort of a perpetual, as well as the annual renewed threats of forest fires. Can you guys just talk about sort of one, perhaps the opportunity to prevent, but then also just maybe anticipating this burden when it presents itself? So, Sanchi, you want to take that one first?
Yeah, so the data on forest fires and cocci is pretty mixed. There was a recent study actually in the UC system that looked at kind of geolocation in the populations around these fires and didn't find an overall increase in incidence after the fires. But when they looked at a couple of individual fires that had a lot of population around them, were really big burning fires, those they could see an increase. And similarly, a prior paper did find an increase in hospitalization in some months after cocci, but I think it's a little hard to tell. There's also the confounding factor that what leads to fire is increasing dry conditions, a lot of winds, and those are the same exact conditions that lead to increases in cocci cases. So whether there's a third confounder that's actually responsible for both might be the case. But I know in California, all firefighters are trained to know about valley fever and their risk of it because of all the soil work they do, the digging. And so just that interaction alone and the case reports of outbreaks in firefighters and among other people, makes us worried for sure.
And I would just add that the historical point first, which is if you want to see that people have been thinking about this a long time, look for a paper where the title is "The Tempest from Tehachapi." It's a paper that goes back about 25, no, it's more like 40 years, from two prominent cocci authorities in California. And Tehachapi is a small town north of out there in the San Joaquin Valley. And there was a windstorm, and that blew from that direction to the north and to the west. And there was a surge of cases as far north as Sacramento, which is at the very which is which is east of San Francisco, so it's fairly north in California. And they got the surge of cases just because of when these windstorms helped disperse the infectious arthrochonidia. So I agree with the way that Sanchi mentioned that. If when the winds help push the fires, they're also simultaneously helping push the dispersal of infectious arthrochonidia from the disruption of soil. And yeah, in some of these reports, it's the firefighters doing their job and digging holes. That's similar to some old reports, for example, of graduate students doing excavations in Dinosaur National Park in Utah. They get a face full of dust and it has coccispores. And and related to this, also related. So that was the past, and thinking about this and looking forward is what I mentioned earlier. Some modeling that suggests that there's a sweet spot in terms of how warm the climate is and how little rain you get. And there's this, I don't want to, the Goldilocks reference makes it sound like it's a good thing to have this just right. Well, in this case, it's when it's just wet enough and it's just dry enough, you get the expansion in the upper several centimeters of soil of growth of cocci. And so now you have a biome that will support, apparently, the local expansion of cocci. And so that's modeling at this point, but the modeling seems to be holding up with additional field studies showing expansion of the areas in which cocci can be found in the soil. So um, climate change does seem to be playing a role in this by expanding, the biome where you can expect to see cocci, and a
Yeah.
lot to be learned.
Yeah. All right. I want to thank both of you so much for just a terrific conversation and for the work you submitted. So thanks so much for being here.
Thanks for having us.
Thank you. Yeah.
Absolutely.
Thanks for
All
the
right.
invitation.
And to our listeners, thanks so much for joining, and we'll look forward to another episode of 10 Minutes with JPIDS. Take care.